So the website is, we've designed it and it's made to put all the resources in one place. So everything will be on there, all the recordings, all the readings and all the handbooks, everything will be there. The website is easy to access, you can access it from anywhere in the UK or outside. It's BHT-IMG.com. You can open from your phone, you can open from your laptop. It can work on either. And we'll just go through it together. So it's it has all the induction day, which is today, will be uploaded and recorded, like we said. And we have forum and Sims. We'll talk about this in a second, which would be a weekly thing or every 2 weeks. And we'll talk about different aspects and all the details of what you need to know and need to learn. And there's also a handbook, which will be very useful for you when you start. Things about life in the UK, setting up your bank account, accommodation, travel, everything about the area and all this. Again, it's all in the same website, will be recorded there. And if you scroll down, there's a page about the trust and the area and things you can do and see. There's some page written by one of my colleagues in Education Fellows as well about diversity, and the library of resources will all be there. If you click on Learn More, the button, it will open this resource. We'll go through this. So everything we have will be here. The induction day, the weekly forum, the SIMS, the handbook, everything will be there. And we haven't started this body scheme yet, but if anyone is interested in finding someone to help or in helping someone who just started, you can register through this and we can match people together. We have resources which will be for CSER route, for medical support workers, and we'll plan some social activities and outings as well. We'll let you know in time. There's also a blog, which is not updated yet, but will be throughout the year. Different talks or things that we find useful, or if anyone has information to share with the others, let me know. You can always put it on the blog. Yeah, so this is the website. Everything will be up here. You can access it. So the vision, diversity, and the area. This is our team, I'll show you. And the resources will be here. So you can go through to the link that you want. The most useful one will be from the library, our educational resources. This will have everything on it. Everything will be uploaded from here. So one of them is the induction day, which you can link to YouTube. So we have a YouTube channel. We'll put it on. It will be private, so only people who have access through the website or we give access to can see the induction day. There's the forum, which is a different page. This is the handbook. If you click on download now, it will actually download the handbook straight away. This is the handbook, still a work in progress, but the initial bit is done. You can find a lot of information from there. There's a checklist of things that you need to arrange. If you missed anything, you can try to work on that. How to get yourself set up, resources for health and well-being, things about accommodation, getting a bank account, all the bus routes, all the train information, driving, cycling, phones and SIM cards. So a lot of useful information, which again will add more and more as time goes on, but this will be useful in the beginning. How to register with the GP, and a lot of online resources which you can use for learning as well. So you can download this from the website. If you go to the online resources and click on the handbook. There's also an IMG checklist, which is this. You will each be allocated a supervisor, education supervisor. This list is designed, it's by HAE. We didn't design it, but it's for international medical graduates who are just starting to meet their education supervisor. So you'll get to see all the different aspects, and you can discuss with your consultant or your supervisor what kind of things you need to cover. It's useful to print this and take it with you when you have your meeting, so you don't miss any of the important aspects. Things like all the support, extra support you need, all the different aspects you need to learn about. This is the checklist. There's also the buddy program, which you can register from on this page. Register for, sorry, and see the resources and so on. So this is the most useful thing. There's also an area, a page about the area, sort of where we are, things you can see, and the links and so on, which would be useful. Also links to a map, so you can see where we are, and links to the trust website if you want to read more about the trust itself. Okay. This is the resources page, and this is our team, which I think you've met everyone today. So this is Dr. Mark Davison will be giving a talk later on, Dr. De Palma and me. And you've met, I'm sorry, and you've met Joanne, and Leanne is also Docs. He was the lead education fellow. So these are most of the resources you'll find on this website. If you have it saved, you'll find a lot of things, and it will be updated on there. If you go back here. Okay, so this is the website, and like I said, we have a YouTube channel which will have lots of recordings. So we also have the IMG forum. So the forum is planned to be sort of every week or every 2 weeks, an hour, maybe an hour and a half, where everyone can come in, and we'll have different teaching things. Some of them will be about clinical aspects, doing A to E assessment, things like prescribing, safety with patients, and so on. Some of them will be about career prospects, so sort of like how to progress in your career, what a portfolio is, how to apply for training, and all these things. And others will be about just communication skills and practice, getting used to the UK and so on. It hasn't started yet, but if you go to the website, you'll be able to register that you're interested in coming to these. And once we do, we'll let you know so we can attend these. The handbook we talked about and the checklist. There's also SIMs for IMGs. We're planning these. So in our trust, we have the simulation team, the Bucks Sims team, which is very good actually. You'll see some of the mannequins that we have, which are very high fidelity, very realistic, and it's used a lot. So we have a lot of sims running every day, so it's difficult to book. But we'll try to book some for IMGs. So we'll do some specific stations. You'll be able to practice on a mannequin with a simulated patient, see things like communication, A to E assessment, seeing an unwell patient, and it's all a safe environment. So you can get to learn and do these things which you're not comfortable with on the ward. Again, if you're interested in these, please drop us on the website your name, and we'll let you know once we've arranged for these. It's a bit difficult to arrange, so please let us know well in advance. The peer support, like we said, will be started. If we get enough participants, we'll try to match people with IMGs or people who have been through the similar process, so you can ask questions and learn from each other. If you're interested in being a supporter or getting some support, again, use the website. And once we have some outings, we'll let you know. We're planning some activities together so you can get to see the area and see everything. We also have an IMG WhatsApp group. I think a lot of you are on it already. If you're not, you can join from this QR code. It's useful for getting information across. It's easy than sending emails, and you'll meet a lot of people. I think there's over 40 people on it now. But it will get bigger as time goes on. It's like a place for everyone to ask questions and just get to know each other as well. So if you're interested, you can join through the QR code. I think that's it for resources. Any questions about any of this? You all have the website or access to the website. So it's bht-img.com, and everything will be on there. I'm on the group, so if you have any questions, just let me know and I'll answer any questions you have. Anything? Yeah.
Is the IMG website only accessible on the Trust intranet, or can you get it from home as well?
Home or on your phone, anywhere you want. So this is why we designed it to be separate from the Trust website. Any questions? You think it's useful or? Anything else you want differently?
So it's a sort of living document, if you like. So it will accrete things. If you want, as Matt said, if you want things on there that aren't on there, then we will do our best to do that. And there'll be loads more resources. It'll be an exponential increase over the next sort of 6 to 12 months. So it will be useful. We want to use that as a kind of platform for you to engage with. My photograph might change when I have a haircut.
Yeah. Okay. So anything else you want to add, or that you feel it's missing and you want to see or get used to?
So would it still be the first thing to contact if someone, I mean, one of the IMGs is having a difficult time in the first few days or maybe a month in this trust, and let's say they get into a difficult situation where they need support, like, should we leave a message in the group or contact the admin directly or contact you guys, or should we contact the foundation manager, people in the postgrad building?
Good question. So I mean, I think it kind of depends on the context of what the crisis is. If it's a sort of acute clinical matter, it's best dealt with within the department that the IMG is in, obviously, because they know the context and the details. But we're trying to create a number of different portals. You can get in touch with, for example, myself or Mohammed directly. Yeah. You could just post something on the site or the WhatsApp group, or you can just email us if it's something that you want to talk about individually. If it's something a bit more generic and it's not personal, etc., then there's the obviously we've got the forum, the WhatsApp group, and there are blogs. I mean, you can if there's a sort of a problem that's not easily solved, but is interesting, and you want to sort of canvas ideas, the website will be a useful. It's not meant to be a place where you sort of complain about people, say, he was horrible to me. She didn't give me a big slice of the cake. He got a bigger slice. So that kind of stuff is not really meant for that. But what we're trying to design here is a kind of, and you'll be embedded within your departments, and you need support within that department.
Absolutely.
Now, if you're not getting that support, then I probably need to know about that so I can look into that. I have to say all the departments are fully engaged with this. So, but it is a new drive by the trust to focus on international medical graduates. And so for some departments, it may be that there's a bit of a learning curve, and there may be sort of a little bit of turbulence maybe as people get used to this. So yeah, I want to know about it for sure, but it does depend on the context. So anything that's clinical, acute, best dealt with within the department, and there will be a head of department. There should be someone who's a supervisor for you. I'm going to talk a little bit about mentors, who may be the supervisor, it may be someone else, but these are people who are interested in your development, but don't have any sort of, maybe not have a sort of, don't see you day to day, but you can go to them if you have a question or a query particularly about the challenges related to being an international medical graduate. So yeah, if I'm not sure how to do venipuncture, well, we can help with that with simulations, but obviously that kind of stuff is best dealt with within a department.
Absolutely.
I don't know if that sort of answers your question. We want to keep a link with all of you, okay? Yeah. But we're not going to be sort of micromanaging things, because we don't. It's just a question of time and also context. We're obviously working clinicians ourselves, but we're very interested, and as you can probably tell by the amount of effort that's gone in, we're very alive to this. We really want to make you guys and all people listening in, and your forebears and the ones that come after, we want you to feel part of the hospital, part of the NHS. You're valued, and we want to develop you. We want you to feel your potential. given the fact that there are understandable challenges from coming from a different culture, different medical training, etc. So yeah, let us know, but exercise a bit of judgment.
Just to emphasize, if you go to the website, there's an IRSP page, which you can put your name and email, anything you're interested in, you can tick and send us the form. If you want any of these sessions, or if you have any thoughts or comments, any suggestions, just send it through this as well. It will all come to us. If you can't reach us from phones or WhatsApp, just let us know through here.
Thank you.
Okay. Okay, I think next we have the cultural differences.
So I just wanted to sort of give you an introduction to what I call cultural dimensions. I mean, cultural differences, it's a sort of similar idea. This is a sort of obvious, it's an obvious topic. I put all the flags on there just to show that clearly the root cause of this is that we all come from different backgrounds. It's obvious, different countries, proud heritages, proud cultures. And this is not about trying to, if you like, merge cultures or change your own inherent culture. This is all about being able, for professional purposes, while you're working, to be able to transition so that you can, if you like, function. There's a lot of work which obviously is well beyond my expertise in terms of social anthropology regarding different cultural dimensions, but this work from Hofstede seems to be quite prevalent in the literature. And this talks about different, if you like, dimensions of culture, which are a little bit difficult to penetrate with the words they've used, but one of them is a power distance relationship that differs between cultures. So, for example, some cultures have a very strict hierarchical structure, so that the person who's in charge or leading is never questioned, and it's not the done thing to question that person, even if it's obvious that that person is making an error or is doing something that's incorrect. Whereas in other cultures, and the UK is one of them, in terms of the professional working life in the NHS, it is encouraged to point out when things are not going wrong, not going right, and challenging colleagues, other professionals, is not a negative thing, it's a positive thing. It often helps with clarification, communication, but it also helps prevent things from turning out the wrong way. And there are lots of mechanisms for doing this, but what you will also get in return is that you yourselves as clinicians are challenged. And for some international medical graduates from certain cultures, that is a new thing and may seem a little bit confrontational, but it's not designed to be, it's not meant to be. If someone who isn't a colleague of yours challenges you about a particular thing, it's not that they're questioning your status or questioning your expertise or your competence. Usually it's about clarification, communication, but also pointing out something that you may not have seen yourself. So it's a positive thing, and you have to see it in that light. And the mistake is to react as if it's a confrontation, because it isn't in 99.9% of the circumstances. Individualism is a dimension where the focus is on obviously the individual, the patient. Particularly in Anglo-Saxon, Northern European countries, there is a focus on the patient-centered care. In other cultures, family is much more important. That's not to say that it's not important in the UK, it is, but an example of difference in cultural approaches may be, in some cultures, it may be seen as normal to discuss important matters, health matters, with the family before before discussing with the patient, whereas it would be the opposite way around here in the UK. So the patient is at the centre. Obviously, there are exceptions if the patient doesn't have mental capacity and so on and so forth, but ordinarily the patient is the centre, the family very important, but only having discussed things with the patient, whereas in other cultures it may be the other way around. So, and this is just to give you the subtleties in differences that can exist. The masculinity domain is really masculinity, femininity. It's more about where some cultures place an importance on goals, achieving targets and tasks, whereas other cultures have much more of an emphasis on holistic care, the perceptions of patients and staff, etc. And if you, in the UK, certainly more towards that side of the spectrum, where inclusivity, teamwork, attaching importance to how the feeling is given a premium, whereas in other cultures it may not be given such a high priority. And getting used to that can take time. Uncertainty avoidance is a dimension that we don't have to remember any of these terms. Is where the approach to risk, essentially. When you're working in a healthcare environment, it's axiomatic because there's uncertainty. You don't have all the information at any one point in time. And how different people from different cultures cope with that is different. As I said again, teamwork is a big part of working in the NHS. It's not okay to be an island on your own because healthcare is far too complex nowadays. Notwithstanding that, culturally, it is expected that decisions are shared, not just with the patient, but also with colleagues, which is why you see a lot of what are called multidisciplinary meetings, where different agencies are talking about the same topic. Now, it may well be that you as a clinician have a very important or even a sort of dominant view that influences the group, but it shouldn't be the case that you individually are making decisions, particularly complex ones. You should always feel empowered to share and say, look, I'm not quite sure this is what I think, but what do you think? Yeah. I think getting used to that can, if you come from a culture where it's very much a sort of, well, I've made a decision, I'm the doctor, we've got to go with that. It can be difficult to make that transition. But it's okay to feel that, yeah, if you like, challenge, but you just have to be aware of it and try and adapt to it while you're working professionally in the UK and the NHS. Now, these sort of complex anthropological constructs sort of intersect, I think, with more obvious levels of culture. So there's an NHS culture that surrounds all of us working in healthcare in the UK, a very centralised national system. There's obviously institutional cultures. There will be a culture here in Buckinghamshire Healthcare NHS Trust. There will be a culture in a different hospital that's slightly different to the culture here. There's also a different educational culture that exists both within organisations, but amongst clinicians in the NHS and many other cultures around the world. So the learning environment that you're in is designed to be inclusive. It's not meant to be judgmental. It's meant to be supportive. It's not meant to be summative. It's meant to be very formative. There's an emphasis on reflection as an ongoing part of your development. So when you finish work at the end of the day, or whenever you have time, if there have been interesting or complex or challenging cases, to reflect and to write down your reflections, and something that maybe we'll have to talk about a little bit later is having a portfolio, which in most instances is electronic, in the absence of that, to have your own risk portfolio. So that may be, if you're a surgeon, a lot of cases. There'll be interesting aspects about a particular case that will make you not only remember that case, but also you'll learn from it. It's when you sometimes detach yourself and think about, reflect on a particular clinical scenario, sometimes with the passage of a little bit of time, you can realise that you could have done things slightly differently. And you thought you did it very well, and that will reinforce that good behaviour. Without the actual active reflection, just going to work and just finish your day, go home and switch off and do other things, then if you don't allow yourself a period of reflection, then that can be detrimental to your education. And certainly in the UK, we're very keen on clinicians reflecting on their practice, and it's a very, very powerful agent of development. Which may not be so important in other healthcare systems. In terms of ethnic, I mean, the ethnic dimension, we are in a very multi-ethnic society here, so it's perhaps not so important in terms of it's not as important as perhaps in some countries where there is a single ethnic group that dominates everything. So you're very lucky in the sense that the healthcare system in the UK, so professionally, is very, very diverse. And we want to protect that and respect that. So that's perhaps not so important, but there may well be issues with patients who are not diverse. And certainly Buckinghamshire, majority of people are white. And how you interact with them may seem different. They may have different views. It's very important to be professional. We will support you. There's no room for any kind of racism or sort of a differential treatment of you because you come from a different background. And it extends across, all, even within the white group. I can tell you when I started, I've got a foreign name, my name is De Palma. So when I started here, a lot of people were kind of would get confused speaking to me, saying, "Sorry, I didn't catch what your name was." Once my dad is Italian, my mum is Spanish, and this person had come back. This anecdote came back from, I think he had a lower GI bleed. He was a cardiac patient for therapy. The GI bleed on a ship in the Mediterranean, retired guy, and he'd been airlifted to Sicily, and he actually had very good treatment, but his cultural background, his own biases led him to believe that the treatment there wasn't very good. In fact, it was very good. And then he was transferred to the UK. He lived in so he came to hospital, and he was very negative about the Italian system of healthcare. And then he caught my name. He went, "You're not Italian, are you?" And of course, I sort of paid him a little bit. So yeah, I'm afraid I am. So and then suddenly he looked ashen. And sort of like, "Oh, I'm really sorry, I didn't mean it that way." So what I'm trying to say, that kind of sort of very micro, I don't know, sort of aggressions or whatever they are, whatever the correct term is, you may well experience that. I'm not condoning it at all. What I'm saying is that your reaction to it shouldn't be aggressive. Okay, patients often are sick, and sometimes, particularly when people are ill, they are, some of their internal biases come out. That is changing. Certainly with new generations coming through, you shouldn't see so much of that. But if there is any discomfort or challenge, then please let me know, and there is a zero tolerance for that in the trust. It shouldn't be that. Yeah, I mean, this is just you don't have to learn this, but just to say that, obviously different cultures do have different approaches to the dimensions, and no one is right. It's just a function of society, and each society has to develop a set of behaviours, values, virtues that are relevant to the situation they're in. So this is why there are different cultures, and it's a wonderful thing. But what we're talking about here is how you can function in, if you like, a culture that may be slightly different to what you work in or have been working in formerly. There are lots of superficial things that you'll notice. Obviously, language is the big elephant in the room. You know, if you can't speak the language, it's very difficult to cross or transition culturally. But I think it's even more complex than that, because you can speak very good, and all of you speak very good English, and just as well as I can. But there are subtleties to language that, if you're new, you may not be familiar with. So people use unusual phrases that are not standard. Even something as you know, simplistic as high blood pressure, meaning hypertension. From some kind of, if you come from certain countries, the use of the term high blood pressure may not be common. How people describe their feelings is often not so straightforward if you come from a different country. I remember once I was working up in West Hartlepool, and I was an SHO in neurosurgery in those days, and in that part of the world, way they describe patients, and also colleagues described, but mainly patients described, that something was good or great or yeah, it's okay, was to say that's champion. Yeah, so some of you may know this already. So I was coming across people saying, "Oh yeah, that's champion, that's champion," and it puts you on a slightly back foot, because you kind of think, maybe I should know what they're talking about, but I don't. And speaking to your point about the self-doubt, these kind of things where you think, well, you know, I'm a clinician, I'm a doctor, I really know what's going on here, and it can undermine your confidence. So this is the importance of interacting with the social gatherings that we're going to try and organise. But you should try and engage with your own departments socially. You will learn all these subtleties by interacting, rather than just closing yourself off and just trying to work in silence. This also links in with the teamwork. The more you engage with your team, the more that they will, if you're having challenges understanding some of these subtleties, they will help you overcome it. Yeah, I mean, these are just sort of a recap in a slightly more concrete term. So the UK NHS, and actually a lot of modern healthcare systems in high-income countries, are very patient-orientated, sometimes described as consumer-orientated, much less paternalistic. And we used to be 30 years ago in this country, but it's not so much now. If you come from a paternalistic culture, it may be a little bit of a transition that you have to undergo when you're working here. So the doctor isn't always right. The doctor isn't in charge of everything. What the doctor says doesn't always translate into an action, because other people have an input. They sometimes describe that as stakeholders, who have a stake in the decision, or just a stake in the patient's pathway. That is normal in the NHS, and again, you have to transition to understand that. Dealing with families before patients, I've alluded to that already. So the families are not important, they're very important, but the patient is culturally, but also legally, the person who makes the ultimate decision. Treatment, for example, discuss it with them. The lack of vertical hierarchy I've alluded to. That doesn't mean that there isn't a hierarchy. There is, obviously, but it's not so rigid. Sometimes people have a flat hierarchy. It's not that there is no hierarchy. You do have to have a hierarchy of experienced others, skills that are to be recognised, and people have to make decisions. There has to be a chain of command, if you like. But this is what this is talking about, really, is the fact that everyone is open to challenge. But the purpose of that challenge isn't to say, you're going to hell, you've made a mistake, or if you're doing it a different way that I want you to do. More to do with trying to help communication, dealing with complex medical conditions. It's to clarify instructions, it's to point out where things maybe done differently, maybe done better that you haven't thought of. So it works both ways. You can be challenged, but you should be challenged because you understand, or if you think clear, or you think something should be done. And that's to be encouraged. And at the most extreme, there are adverse events that inevitably happen, is human. There is a system called DATEX, which is an electronic system where if there is an adverse event, you details in and it's reviewed to see how the learning from that improves care for everybody else. So this sort of lack of vertical hierarchy is actually a positive thing, and you should see it as a threat. The system checks, there are lots of processes which may seem overly bureaucratic compared to other cultures. These system checks are designed really to try and enhance safety. Sometimes they also slow pathways, they slow decision making down, and that can seem very frustrating. Those systems haven't been created for you guys or me, it's just the culture. And it's born of the fact that medical care, as I'm sure you're all aware, is very, very complex nowadays. And that translates into, compared to 50 years ago, fantastic outcomes for patients with very difficult conditions. So although it's a twin-edged sword, sometimes it's overbearing and be more complex than it needs to be. But the intention of these system checks is really to try and safety. Education, as I've alluded to, in this trust particularly, but in the wider NHS, the learning environment is very important. We put a premium on that. You're here to learn and develop, and it's not meant to be a summative thing. And there will be lots of soft skills that you will need to learn. One of them is reflection. One of them is another is recording your learning events on a portfolio. But making use of all the educational activities that are available, it should be a priority for you. This might be, how to break bad news. It might be how to deal with a challenging patient. It might be to lead a team. These sort of soft skills are also part of your education. You should avail yourself of those opportunities. It's by gaining experience, training in those areas, you will be able to transition when you're working professionally, all cultural challenges that exist. And then, the primary care system, probably many of you have come from cultures where there is a strong primary care system, others less so. In the UK, there is a strong primary care system, and understanding that the primary caregiver, in other words, the general practitioner, is legally entitled to have all the information about the patient. So if something happens to a patient in hospital, the usual mechanism of the patient is a discharge summary. Now, that may be unusual from certain cultures, but they do have a legal right, and it's also part of the culture that the GP is the centre of the ongoing care for a patient. So communicating with them is very important, and maybe a slightly different way of doing this compared to what you're used to. There are some very useful, say, animated cartoons that we will post on the website that talk about the wider NHS and how different bodies within the NHS work with each other. So you don't just have hospitals, you don't just have hospitals and primary care providers, you've also got health and wellbeing boards, or body called Health Education England that oversees education for all the clinicians. How those interact are very, very complicated. And this animation that we'll, in fact, I don't know if we've got time, maybe we can show this. Gives you a taste of how it all links together. And I think, yeah, I mean, I just wanted to say how to overcome these challenges. I believe this is, you do need to, the most important is to be self-aware, to be aware of your own cultural background and how that's sort of the differences that might exist. It's not to change your culture at all, it's the opposite. It's just to recognize it, to be aware of it, and to be aware of the professional culture to which you are now embedded. Find mentors. Now we are going to set up a buddy scheme for you, which will be a kind of mentoring scheme. But you can set up your own mentoring. You know, if there's someone who you connect with that wants to be your mentor, you need to seek them out. And someone that only you will know if someone is kind of interested in your progress. There's usually a handful of people when you're going through a hospital hierarchy that will be interested. But you only need one. And it's someone that you can go to if you have some questions, just to let them know how you're getting on. And they can give you ideas. You can bounce ideas off there. Obviously, it's just this one way of doing it. Buddy scheme that we're going to try and set up will be another. Obviously, you'll have friends and family. So there are lots of avenues to try and obtain a type of mentor. You mustn't feel that you're on your own. And if you are stuck in terms of not having anyone to, not being able to find a mentor, do come and find me and Mohammed. We will do our best to help you. Because there are lots of people out there who are just waiting to be asked, but don't want to offer because they don't know whether you want them to be your mentor. So there is a kind of, a little bit of a barrier there sometimes. But we will facilitate that. And also, just as I said, you make the most of all the opportunities, particularly the ones that we're going to try and organise for you, because our focus is really to try and help you your potential. It really is to try and help you develop. And we won't get all the things right, but I think that we made a good start, and there's more to come. And your input in shaping that will also be important. It's part of the culture. And you challenging us in terms of what we're providing for you is also important. So please feel free to do that. I think that's what I'm going to say. Culture is a huge issue, and it's an evident one when you use the NHS, use working here. But all these problems or challenges can be overcome with a bit of application. We recognise they exist, and we will help you transition. Anyway, over to you. I don't know.
No, you've just done all my slides for me. Keep going now. Good morning. Welcome to the Trust. I'm Nick. I'm one of the consultants in infectious disease and microbiology, and as Robin said, I'm also an infection control lead. I've got Savitha with me, who's a matron in infection control. I think one of the take-home messages really is don't hesitate to call us for advice. If there's anything you don't understand, or you're confused, or you're worried, or you don't agree with the consultants, just call us. We will do what we can to help you. It's a scary journey. We recognise that, especially for junior doctors and for you guys as well. And there's a lot of uncertainty. I mean, certainly myself, Savitha, there's a lot of questions that we get we can't even answer, but we try our best to tackle it. So we'll do this together, but don't hesitate to give us a call. Yeah. So we're gonna tag team, Savitha and I. She's gonna do some bits and I'm gonna do some bits. And if you don't mind, I'm gonna do some microbiology as well, because it's really interesting. And I want to really entice you into understanding antimicrobial stewardship, because that's a real problem now, certainly in UK and around the world as well. So we've got to be really, really focused on what antibiotics we use. And you are the people who really will be prescribing anyway, but please question, if you're seniors, no offense, seniors, say, I want this, I want that. Do ask the question, well, why are we giving this? This is not what the guidelines suggest, or hey, think about interactions as well. I think that's the one thing that people don't recognize is it's easy to just write Comox or Cipro or whatever, but think about interactions. So if patients are on antidepressants, etc., there could be interactions between antimicrobials as well as what their pre-existing medications may be. And if you, in an ideal world, you have ward pharmacists who are there to say, hey, these two interact, instantaneously. But sometimes, and in most cases, they're not always around. If you need help on that, I think on Up to Date, which you guys know about, I'm sure, there is a tab where you can look at clinical interactions. And when you click on that, you can list all the medications that patient might be on and see what interactions there might or might not. I find that really helpful because you kind of understand in medical school things like rifampicin, like ciprofloxacin, enzyme induction, enzyme inhibition, and things like that. But have a think about that. Last thing you want is someone to have a long QT and die, because that can sometimes happen. So anyway, enough of that bit. I'm going to start with the birth of IPC and hand hygiene, which you've already explained. Semmelweis, Hungarian physician, I think Austro-Hungarian, back in the 1800s. He was a bit of an eccentric physician, really. And I think he was the first to actually think about hand hygiene, as mentioned already. So in terms of obstetrics and gynecology, what he was noticing was basically that there was a spike in what's called puerperal fever, which is basically post-delivery infection of any sort, whether not be Group B strep or Group A strep or any other infection. And he thought about it quite a bit and thought, actually, let's try chlorine hand washes. So if you go back to this picture, you see that on the left-hand side, this doctor in blue, well, I think it's a doctor anyway, and the person in the corduroy can kind of washing their hands. I think that's chlorine, basically, washing their hands. And he noticed that as soon as he enforced this chlorine hand wash, the actual incidence of fevers drastically reduced. But what was really interesting is he didn't write this up and really didn't tell anyone about it. And it wasn't until I think Louis Pasteur and others kind of about 30, 40 years later, and Joseph Lister as well, that's when it really got on to normal practice, really. So even back then, we realized hand hygiene is crucial. You know what I'm going to say, hand hygiene is really, really crucial. I'm going to bring on to Savitha now to talk about transmission routes. And she's going to go through quite a few slides about various different bugs, surfaces, etc. And I'll do some micro in a minute.
Hi again, everybody. Again, it's just making sure that the transmission routes, and I know everybody knows the hands and where Dr. Wong said about the hand hygiene, where it shows about the reduction of puerperal infections. That's where we are saying about it. And one thing which we all have to understand is we always say about the hands, and it's not just our hands or patients' hands, it's the environment where they are as well. So that is one of the areas where we see the infections transmitted as well. One of the observations what we have seen is, I'm giving examples with the doctors, as you're all the doctors group. You go around with the patients, with the consultants for the ward rounds. It will be the group of doctors, and then one person will be doing the curtains, other person will be doing the notes, and then the person who's doing the curtains never clean the hands between the patients. So I have not touched the patient, but the curtains which is within the patient is an infectious area as well. So it's not just the hands of the patient or if you touch the patient, but it's mainly making sure that the environment of the patient area is considered, making sure that you clean your hands as well. Again, this is where the importance of the cleanliness of the environment comes in. Clostridium difficile, there was I think in one of the NHS hospitals a long time ago, the C. diff, and then everybody thought you clean it and then it's all sorted. But even after 9 months, they were still having hospital-acquired C. diff. And the cases where it was seen that C. diff spores were in the radiator. And you think, how does that spread? So that's why it's just making sure that we clean the environment. And C. diff, as you all may know, it's a spore forming. So the normal cleaning enzymes won't clean it. You need a special sporicidal wipes for it. And Acinetobacter is 3 days to 5 months again. Enterococcus 5 days to 4 years. Pseudomonas 6 hours to 16 months. Klebsiella 2 hours. So even though you can look into it, influenza, again, hours to several days. There is no in any of those, the minimum are hours, the maximum are 16 months, 30 months, which shows that even if we don't have, make sure that our hands are clean, but the environment needs to be clean as well. In that way, there are loads of incidents where we have heard about the SIMS as a transmission route for CPE, pseudomonas and everything, and even the MRSA, just the nebulizing machines where they leave it and they keep it. Because if the patient is in the hospital, say about even 2 months, nobody care about changing the nebulizer kits, and it stays there. And in that way, the MRSA has been transferred to the patients as well. Surface hands and patients, that's where all we have to look into it. That's, you can see the gloves is there. We, from IPC, from BHT, is about to roll on a program that reduce the gloves. So I think everybody has an information that if you wear gloves, it's all sorted, isn't it? My gloves are fine and that. So what we really have to look into it is not just wear the gloves, making sure you clean your hands before and after wearing the gloves. Reduce the use of gloves because it's mainly, some people might say, oh, is it because NHS don't have the money? It's not mainly because NHS don't have the money. It's so many things related to it. But one is looking after yourself. Contact dermatitis, increased use of gloves can lead to contact dermatitis. And the other one is the environment. The more plastics things you use, it's more to the environment. And then you use the gloves or not, the hand hygiene is important there as well. I'll go through with the transmission-based precautions where I'm not reading all those things, but 5 moments of hand hygiene. I mean, basically, as I said before, it's just making sure it's not just touching the patient environments as well. And before and after, most of the time what we have seen is staff doing their hand after touching the patient because you're conscious that you're dirty. But before going to the patient, the use of hand hygiene is very, very less. Because you just don't feel yourself as unclean, you think, okay, it's the patient's unclean. And then what we see again is when we see people walking around with a PPE and when we ask, oh, why do you walk? Oh, I'm clean, I haven't touched anybody. But you're not thinking that it is going to the patient's side. You're giving something what you have touched everywhere as well. Again, this is one of the most important things, standard precautions and transmission-based precautions, mainly for the infection control. And the standard precautions basically comes everything: patient placement, hand hygiene, respiratory and cough hygiene, personal protective equipment, safe management of care equipment, safe management of care environment, safe management of linen, safe management of blood and body fluid spillage, safe disposal of waste, occupational safety, and immunization for sharps management as well. This is basically how you should be looking after any patient. This is the standard, irrespective of the patient has any infections or not. And then making sure, one of the important bits as junior doctors or the people who are coming into the medicine or into the field, I just have to say importance about the occupational safety as well. It is again ourselves, it's not just for the patients. If you ever have any needle stick injury, any splash injury, you comes first. Make sure you look after yourself, okay? Don't be scared of to report it. Don't be scared or don't think that, oh, it's okay, I have done everything. But please make sure you do the necessary things. Report it, get the occupational health check accordingly. I always say this example, I had one of the worst nightmares, not nightmares, I would say. One of my nursing colleagues had to quit nursing because she had the needle stick injury. But she didn't report it to anybody then and there. And then it went with her for a few days. And then she reported it. And then unfortunately, that patient was HIV, hepatitis B, HCV positive. You think how on earth this patient got everything. And poor patient was a kidney transplant patient. But the worry of the staff to work in the nursing field made her to quit nursing. And I always say this example to every newcomers to medical and nursing field, because if you inform because she didn't inform thinking I will be told off because of not doing things properly. When anything happens to you, there is no told off coming in, it's looking after yourself. Okay? please make sure whatever happens, look after yourselves as well. So that's one important thing which I really wanted to say in terms of occupational safety. Making sure if you are vaccinated, I know everybody have to vaccinate against hepatitis B, sorry. And my staff in that scenario, she didn't vaccinate against hepatitis B. As a nurse, she was still scared of injections. She avoided injections all the time, and she avoided all the occupational health appointments. She didn't do it. And then that was the worry for her. I haven't done the vaccinations. If I say I have a nail stick injury, the first question they might ask us, where is your vaccination? Why have you not done it? So if there is anybody who has not had the vaccination, and again, it's all, I know to an extent it is the personal thing, but it is, if you haven't, feel free to contact the occupational health and make sure that necessary arrangements are made. Transmission-based precautions, as I said, the first one is standard precautions, irrespective of what the patient has, you use all those precautions. Transmission-based precautions is depending on what the patient has, infections, what they're having, and then we have precautions according to the transmission of that infection. Say, for example, COVID, what precautions are the most important?
PPE.
PPE, within PPE, what is the most important for COVID?
Mask.
Mask is the most important. And me and Dr. Wong really hate people when we see mask on the chin, mask on the neck. If you wear the mask, wear it properly. Otherwise, wear not. Because if you wear it here, you yourself is creating a problem for you, because you put it in, your hands are contaminated, and then even here you do it in. So just make sure when you wear the mask, wear it properly, otherwise there is no point in wearing it. And contact precautions is like things like MRSA, CPE, CRE, C. diff, and all those things is like where you in contact and then you can transmit the infections. In those cases, you need the making sure that the gloves and aprons are the important thing. Airborne precautions is mainly, again, here in our trust, we have gone with airborne precautions for COVID. So what you might think, what's the difference between COVID, airborne and droplet? Droplet precautions, we use mask. Airborne precautions, we use FFP3 mask. So for all COVID suspected or confirmed cases, we need FFP3 mask. And the important thing about FFP3 mask is making sure it's fit tested. Because if you don't use a fit tested FFP3 mask, it's only providing you with a surgical mask rather than an FFP3. Because I have heard quite recently stuff saying, oh, whatever it is an FFP3 mask. Yes, it is FFP3 mask, but if you're not fit tested against it, it is not serving you as an FFP3 mask. So make sure the departments where you are, there is a supply of FFP3 mask. I always carry one FFP3 mask in my pocket because you don't know what's happening, where is the emergencies coming in. I'm not telling you always you have to do it, but it will be worth checking the departments where you're working that the proper FFP3, your fit tested FFP3 mask is available. And if it is not available, we have a fit testing team here. You don't even have to make an appointment. You're free to walk in and to do an FFP3 fit testing. I think I've covered most of it, but this is, again, there is no must PPE that you wear for every certain conditions, but this is what we always want everybody to risk assess and then wear it. Surgical mask, as we said, for the, again, you know what, one thing what COVID has brought into attention is people were not wearing the proper eye protection or face mask when they should be wearing, because it's not just for droplet. If there is a splash suspected, then in those cases, you have to protect the eyes and your face as well. So that's why, because we realized, I think it was, I'm not saying which department it is, one of the department where they should be wearing, they were not wearing it because they were saying, oh, we don't have any eye protection and stuff. We said, you should have it. Oh, we were not using it. So that is where the COVID has brought with the PPE informations as well. And then gloves are not required if there is no anticipated exposure of blood and body fluids when you are not providing personal care. Because If you're just with the patient environment and think you have to wear the gloves, you don't have to unless there is no anticipated blood and body fluid exposure. Especially what we see is doctors putting all the PPE, writing down the notes in nurse station, going with the same PPE to the bedside and writing it down from there. So PPE, the most important thing is start and remove it from the point of care. Don't walk around with the PPE if you have it the patient or not as well, and making sure you clean the hands before and after removing PPE as well. This is the current PPE guidance, so there is no must for everything. It is according to the risk assessment, because previously with the eye protection, even it's just making sure that you risk assess and then do it. And it's just the reputation. Yeah, microbiology comes in. Thank you very much.
Thank you.
So there are a few anecdotes from what Savitha just said, and I can kind of recount one or two things that I remember, apart from, obviously wearing the mask badly, is during an outbreak on one of the wards, we decided to do some environmental swabbing to see how good the cleaning was, covering the standard precautions. And we swapped keyboards and we found COVID on the keyboard. So think about the surfaces that you use, before and after. So we always advise staff to clean surfaces when you've been before and after use. So please make sure you do it, because you don't know who used it before, how good or bad they were with their hand hygiene or PPE practice. And of course, the other thing is, as we mentioned about gloves, is, don't think gloves mean I don't need to wash my hands, okay? Because I think gloves are probably as dirty as anything. And a lot of people think that gloves are that's good enough. It's another barrier. The problem with gloves are they don't fit you tightly, so the surface area is increased, and you have no idea what bugs or bacteria or viruses may be living through the creases that you're potentially transmitting to other areas. So I'm really going to entice you and interest you in a bit of microbiology right now. So it's back to medical school days. Hopefully you remember some of this stuff, but these are the common things I worry about, and these are kind of things that you may want to call me about. So gram stain, this man Gram, Danish bacteriologist, he invented or came up with the actual various different dyes that you use for the gram staining. And why is it helpful? Well, you may remember that bugs are split, or bacteria are split between gram negative and gram positive, depending on the presence of the peptidoglycan outer wall. And the actual staining itself, depending on which process, will elicit whether or not there is the presence of that peptidoglycan wall. So in the gram positives, it's seen it's not in real life purple, but you can see it's purple. So when we see something under the microscope that's gram stained purple, that's gram positive, and when it's red, i.e. lack of or very little peptidoglycan, it's red. So I'll show you some pictures. This is Staphylococcus. It's a cluster, a bunch of grapes, which is what the staphylo actually means. And you can see that's gram positive. Whereas this is gram positive, kind of gram positive in chains, streptococci usually, or enterococci. And this is gram negative, and they're rod-shaped. So these are things like E. coli, for example. Then you've got these things, which kind of look like gram positive cocci, but they aren't really. And if you look carefully, you can see that they've got this kind of little kind of indolent or budding areas. So these are yeasts themselves, things like Candida, for example. So we'll look at all these kind of things under the microscope and contact you if anything comes up. But you've got to also understand, we can't predict or say, oh, that's a Staph aureus or that's a Strep pyogenes, etc. We can only give you a hint from what we see in the gram stain. From there onwards, we then have to incubate, and what we do is we actually, those agar plates that you see in the labs, etc. We have to try to grow these bugs, and then we can identify. So sometimes there's a delay of at least, we would say, about 4 to 12 hours before we can give you an identification. And sometimes it can take a bit longer to know what the sensitivities or susceptibilities are, to which antibiotics are sensitive or resistant. So I'm going to go through some cases, probably very easy. First one, this is a patient, I'll say 85-year-old, 2-3 day history of type 5 diarrhea. Hopefully you know what type 5 means, Bristol stool chart. So Bristol, they came up with a stool consistency chart. I love this chart. Basically, you might have seen it. It's a picture of how how solid or how liquid the stools are. So it's a scale of, I think, 1 to 7, 7 being completely watery diarrhea. 5 is where it becomes quite loose and kind of watery. And our guidance suggests that if it's type 5 or above, that's when you worry about things like, well, C. diff or an infected diarrhea itself. And those are the ones that you want to send. Anything 4 and below, probably more solid, probably normal. Now, I've done a study on this and I've actually presented it. If I asked all you guys to grade people's poos, disgusting as it is, I'm sure there'll be some variance. Okay, not everybody will see a grade 5 equally, but what we know is that grade 7, everybody agrees on that. So there's always going to be some discrepancy, but think about it, you know, look at the charts when you do your ward rounds. Don't rely on the nursing staff telling you, oh, this patient's got loose motions. It is your responsibility as well as anyone else's to look at the stool charts. So anyway, 83-year-old, 2 to 3 day history of type 5 stool, recent exposure to Coelmox. What's the likely diagnosis? C. diff, isn't it? So what other factors, risk factors should we look for? I'm not going to kind of drill you on these. So C. diff basically is, you know, spore-forming bacteria, okay? Hand washing, really important, okay? Can be part of normal intestinal flora, okay? But major causes pseudomembranous colitis and death as well. And obviously, it's a big problem, okay? In the UK itself, because of the number of C. diffs we have in the hospitals, we have a limit to how many C. diffs we have. I think it's a bit wrong to give us limits. We should try our best to reduce it anyway. And we have to work together. A lot of the time, GPs may have been given all sorts of antibiotics or broad spectrum antibiotics, but we ourselves in the hospital need to have good control on that. And that's where you guys come in as well. So risk factors, as I said, is antimicrobial use. Think about PPI use. There will be some patients, or most patients, who are on some sort of PPI. Think about it. If they're on it and they've got loose motions or they've got C. diff, change that to an H2 antagonist, the Motivine, okay? We will do ward rounds once patients have got C. diff, toxin positive results, and we will come on the ward and talk to you guys about it. But anticipate that, okay? Things like repeated enemas, GI surgery, and food, of course. There's an obsession with food and Yakult and things like that associated. But there's multifactorial. But when we have a C. diff case that's toxin positive, we will investigate it with you guys. And we will try to look for any concerns about lapses of care. Usually, it's antimicrobial use, okay? Then I need to talk to you about colonization and toxin positive. This is where it gets really complex in all levels because of the testing that we do. We do 3 tests. We look for GDH, we look for what's called the toxin PCR, and we look for the toxin A and B gene, okay? If you've got the toxin A and B gene, that's the one where we say they're toxin positive and they need isolation and they need treatment with oral vancomycin, for example. However, a lot of patients can be colonized with C. diff, so they're not actually producing the toxin, but they're colonized. So in those situations, we just recommend isolation, okay? And that's it, no need for treatment. However, if they persist to have diarrhea, etc., call us and we'll look for other bugs as well. It may be that these patients are at risk of getting toxin positive C. diff eventually. So those are the ones that we need to be a bit careful about with antimicrobial use because that might just tip them over and give them the toxin positive. I'm not going to talk about that. I'm going to talk about severity. So you've got mild, moderate, and severe C. diff. And the thing to think about is the white cell count and also the rising serum creatinine. These are the prognostic factors of badness of disease, basically. And despite the fact that treatment is very similar itself, those are the kind of key things you need to be aware of. And then, of course, life-threatening and things like hypotension, partial or complete ileus, and toxic megacolon, which you've all read about. I've had a few of those actually in the past. So then site is really important. And I'm sure if you look at the micro guide, hopefully you've all downloaded the micro guide, you'll see, I think it's guideline 225. But it will have site basically. Think about these things, okay? So S is suspect that a case may be infected, isolate the patient, so don't wait for the results. If they've got diarrhea, isolate them. Gloves and aprons should be used. Hand washing, crucial. Don't think of gloves as equal to hand washing, do both. And then test the stool for toxin. We usually get a result within a few hours and we'll call you guys. Treatments, This is a bit boring. I'm just going to go through it really quickly. Vancomycin is the #1 treatment of choice. However, we sometimes get what's called relapses and recurrence, which people, including myself, get confused about which one is which. Relapse is defined as a further episode of C. diff infection within 12 weeks of a symptom resolution, whereas a recurrence is defined as a further episode of C. diff infection more than 12 weeks. So the crucial factor is 12 weeks. Okay? Treatment is slightly different. For relapse, we give something called fidaxomicin, which actually costs much more than oral vancomycin, but has been shown to be actually superior to vancomycin in terms of reducing bed days. But for recurrence, we would recommend oral vanc, although you can use fidaxomicin. And then for those bad C. diffs, we think about rectal installation of vancomycin, sounds horrible, or even fecal microbiota transplant, so fecal transplant. So these are wonderful people from around the country who've donated their poos. They then get checked to make sure that they've not got like horrible things in them. And then that gets instilled in that patient through an NG tube. And I've had 100% success. I know you're making that face. 100% success with that one. And no, although you can smell it, they don't feel it. It feels cold because you refrigerate the poo. There we go. You got to remember that now, aren't you? Case number 2, you know what that is. Basically, it's meningitis. Okay, it's a notifiable disease. You have to call the public health people to let them know. Diagnosis, you know, blood cultures, LPs, PCRs, throat swabs. The treatment is ceftriaxone. If they're allergic to penicillins, give us a call. It's usually chloramphenicol instead. Case number 3, pretty horrible skin. I think that's a leg. You see gram-positive cocci in chains. So there's a streptococcus. Which type it is? It's strep pyogenes or group A strep. Again, a notifiable disease because this is necrotizing fasciitis. And treatment is not antibiotics alone. It's surgery and antibiotics. So again, these are things that you may come across during everyday life on the wards. This is the one that I'm going to spend a few minutes on. 60-year-old, as you know, we've got a world famous spinal injuries unit here. We've got spinal injuries patients who stay in that unit for years, basically. They're paraplegic, they get recurrent UTIs, they've been on every single antibiotic known to man, okay? They've been staying there, they've got chronic pressure ulcers because obviously they can't really move around, and they've had multiple debridements. So loads of antibiotics, lots of debridements. This is the first result you see. So it's a bit complex. This is what we see in micro. Luckily, you don't get to see this. We deal with this. This is a sputum sample, okay? It's taken 2016, and it's grown E. coli and Klebsiella. Where you can see below in red and green are the antibiotics for which they're susceptible to. So S is sensitive, R is resistant. You can see from that pretty much the Klebsiella number 2 is only sensitive to colistin. And the only antibiotic available for this patient at this point of time for the sputum is colistin. Okay, so you start colistin. And then basically a few days later, you get a tissue sample. They've had a debridement. And what do we grow? We grow Proteus, E. coli, Morganella. Again, super resistant. Okay, not many options to go for. And then the next thing you get, and in fact, another tissue sample, we've now got a few more beasts. We've got vancomycin resistant enterococci. We've got a Staph hemolyticus. This is now a nightmare, okay? A puzzle. It's like a Sudoku puzzle. What do we do with this patient? Because whatever you give, it's going to become resistant very soon. And then the next thing, I think, is another tissue sample. And we're growing, I think, Morganella, which we said before, E. coli, and a coag-negative Staph. And then I think, finally, a blood culture. We're now growing MRSA. Great, isn't it? So essentially, why has this happened? Well, patients actually had chronic stay, had lots of different antibiotics. Could we have predicted this? Possibly. Difficult to know. We've got to be really good with our antimicrobial stewardship. So with the spinal injuries unit, we have a weekly MDT where they go through all their complex cases, and we kind of limit. Because my obsession is not the choice of antibiotic, it's also the duration that you give. And so I see it so often, and certainly in the respiratory areas, they give 2 weeks of tazocin, for example, and and that is really bad practice. We should be thinking about narrowing, and I'll go through that in a second. But in the meantime, I'm going to talk about CP or CRE. These are carbapenem resistant Enterobacteriaceae. These are the bugs that are resistant to meropenem, or they basically, a lot of people say the kind of last antibiotic to use. Okay, this is becoming a real problem nowadays, and you can see that the rates are going up and up. Back in the early 2000s, there was very little. A lot of it's been imported from other countries, developing countries, for example, but it's getting more and more prevalent now, and some are actually homegrown as well because of our bad use of antimicrobials. So this was Europe back in 2009, 2011. Obviously, green is okay, but not amazing. Red is bad, and the darker you go, the more likelihood of percentage resistance you see. So over the course of 2 years, you can see it's spreading from Greece all the way to Italy. And now look at it. It's and that's not even now. I think that's 2018. I can pretty much say that it's all that kind of maroon red color, pretty much in the whole of Europe. So we're seeing it a lot now, and this is a real problem because we're running out. People aren't inventing new antibiotics. Antibiotics are, they just add a new chain to something that's already existing and hope for the best, basically. So CP cleaning, these are all very decluttering, disinfectant. You can use hydrogen peroxide vapor, which we can do that, but we don't. And then how to help? Well, wash your hands. We talked about this. Wear correct PPE, universal precautions I've discussed. Document insertion of lines. We get a lot of line infections, and VIP charts. You guys had a VIP charts, the actual scoring of the area where you put lines in, from a scale of 0 to whatever. That usually is done by nursing staff, but don't rely on just the nursing staff. You guys need to look at all various different lines too, because we should not be getting line infections from cannulas like Ventlons. That should never happen, but yet we've seen them. And every time we see them, it's a lapse of care, and it ends up being a serious untoward incident. There's been negligence in recognizing that situation. It should never happen. These things should be removed. Maybe antibiotics should be given if there's cellulitis and some surrounding cellulitis. Things get forgotten because you guys are so busy. You're running around like headless chickens. You don't get to know your patients well enough. But these are the basic things you need to really learn and make sure that it doesn't happen. Otherwise, I'll have to go through an investigation with you, and it's not nice. Although I'm quite a nice guy generally. Practice good antimicrobial stewardship and clean items used between patients as well. Stewardship, I've talked about this microguide you can download. You may have heard of the Start Smart and Focus situation. I'll go through that in the next slide. Allergies. Ask allergies. Everybody writes penicillin allergy, but whenever you guys call me advice and say, oh, this patient's allergic to penicillin, and I ask, what is the allergy? I don't know. Okay? Don't just write penicillin, ask them what it is. It's usually a rash when I was a child 80, 90 years ago. And when that happened, that was when penicillin was pretty horribly contaminated with urine and things like that. They used to actually filter it from urine back in the day. So, it's much better now. So ask and think about it, because you don't want to be limited with the classes of antibiotics you have to treat this patient. Obviously, if they're anaphylactic, that's another issue. And think about the ARC study. Hopefully you've been taught about that. It's the antimicrobial review kit, which I'll go through again. So Start Smart and Focus. Microguide will give you the empirical treatment. So if patient comes with sepsis, this is what you give. Straightforward. But within 24, 40 hours, maximum 72, think about whether or not you still need that antibiotic. So I refer you back to respiratory, giving 2 weeks of tazocin. Does this patient need tazocin for 2 weeks? Usually within the first day or two, you've figured out what's going on. Oh, it's urine infection, urosepsis, chest infection. You don't need tazocin. Downgrade. And I think the impact of COVID has actually given us a rise in the amount of antimicrobials that we use, not just us in hospital, but in the community as well. The antimicrobial review kit, or the ARC, basically in a drug chart, you'll see where the arrow is, possible, probable, confirmed. To be really clear on prescribing, really review after 2 or 3 days, does that patient need tazocin? Has it been micro approved? Have we spoken to micro? So yeah, that's basically that bit. Nearly done yet. COVID.
Yeah.
Is that you?
Yeah,
Just 2 slides.
exactly. We don't need much slides with COVID these days. It's in there. It's nearly 2-3 years, everybody. I mean, one of the important things which I really wanted to say is couple of things again. There's a whole lot of changes for COVID along the years, and we thought it was going to be stable, but there are more changes coming up as well. So currently, the practice for COVID testing is, again, even though I say this now, there are changes coming next week onwards, but I will say what we do now. Currently, we test for all inpatients, asymptomatic or symptomatic. We do, if they're coming through A&E, we ask them to do a point of care test and a PCR. That's all we are doing. And if they are negative point of care, they can place anywhere. But all the point of care tests have to have a parallel PCR. And then depending on that, what happens is point of care is negative, PCR is positive. And then it can happen the other way around as well. Point of care positive, PCR negative. Sorry. Yeah, PCR negative. In those instances, we ask to do a repeat PCR once more. And if both are negative, if the patient is asymptomatic, we can ask them to step down the precautions. One of the things what we usually see is doctors request for a COVID test. And then they don't say, oh, we don't have to do an isolation. Why? Oh, because it's not likely. It's just to rule out. What we always say is any infection, if it's especially if it's a respiratory, we have to make sure that it is not first and then make sure it is, and then ask to do an isolation. I know we are very, very short of single rooms within our trust, but just make sure that the nurses say to the nurses, this patient requires an isolation single room, and then make sure. And then the difficult part of the doctors is the PCR comes back negative. And then we from IPC say, oh, the doctors have to make an assessment, say yes or no, whether it is COVID likely, and they have to document it. And that's all the doctors do say for that, because I can't very well say whether this is COVID or not. It is a really tricky situation for the doctors because the symptoms will be there, but the COVID PCR is negative. What we always say is don't just go by the PCR. Even if the PCR is negative, review the patient on a regular basis, and then you can rule out. There are other investigations as well, chest X-rays, CT scans, and everything. And based on that, do it. Because again, this is from experience, what we have seen is, oh, the COVID is negative, doctor has stepped down. We don't just want that PCR is negative and then stepping down. Review the patient and then step down the precautions. And yes, again, as we said about I'm not going in detail with the FFP3 mask. One thing which I really have to say is, again, consultants, please excuse me. We have seen some of the senior consultants within this trust reusing FFP3 mask. Okay, the rationale for them is, I have just been with that patient for 2 minutes. It feels very bad for me to discard this mask. So what does that consultant do? Go and hang it on in the nurse's station. Is that a good practice? No. Are you worried about the cost of PPE? Or should we be worried about the PPE cost and reuse? No. Okay. So you are going ahead one day to become consultants. So whatever you are, please don't have this practice in you. Okay. Any PPE, you use it, dispose it then and there. Even if it's for second or something, don't think that, yeah, how come I'm just disposing it, just going to a patient. So any PPE, please don't put it in your pocket. Please don't hang it on. Please don't nurse the station, because this is all the practice that we have seen even quite recently. So just making sure that the PPEs are not reused. And then the other one is, again, this has not happened recently. Again, this has happened before. Doctor is unwell, but there is no other doctor to cover. This was pre-COVID, and she was very low and came for duty. And then on duty, sent us off for flu. Test positive for flu, working in pediatrics. Is that helpful or is it not helpful? When you are ill, I know we are all probably sometimes culprits of this one, I have to say as well. But a couple of things is, if you're unwell, please don't come to work unless that is sorted. So that it's respiratory. And while at work, please don't send a sample saying it as what 5 or what. That's what happens. And then we, to a microbiologist, when they bring the results out, so and so patient is positive. Oh, we don't have a patient with that name. We never had that. And then we look into it, and then it was, oh, it was one of the doctor, or it was one of the nurses. So even if any of the nurses or somebody asks you to do the request form while they're away, please don't do it. It has to go through the proper channel. They shouldn't be at work if they are testing at work. That's some of the things. Nothing else? Yeah, this is what we always ask to do the COVID triage to do. I mean, just making sure that they are not COVID symptomatic. This is what we ask for on our admissions. Our patients needs to be completed so we can risk assess at the beginning as well. And measles, yeah, I think one thing is, even though I said we test for PCR and COVID, currently there is a plan to stop asymptomatic testing for COVID the coming weeks. Yeah, so that
We'll see.
We'll see. So that's why I said, keep you updated with the communications. I know you might say, we always say, we are clinical, there's no time to sit in front of the computer, but just make a habit, one way or other, just see what is in the communications, or within your team, if there is a WhatsApp group or something, just get that information set on, because nobody has the time to sit and look into the emails all the time. But that changes. We do say that you have to say in the safety letter and everywhere, but just make sure that communication. There's 2 more slides. I let.
Yeah, so one thing I would recommend is you will probably use lateral flows for COVID. You can get them as your healthcare professionals. I'm not saying do them, which is what we used to recommend. Get a box at home, just in case you become symptomatic at home. You can do a quick test yourself. You probably already do that. So have that in store. We thought about measles because measles is coming up, because we had a kind of MMR kind of news headline saying associated with autism many years ago, and a lot of parents decided not to give their children MMR. And in fact, the first day as a consultant here in 2018, I had a 19-year-old with measles, and it was pretty horrible. And it actually made the headlines in Antigua, because that 19-year-old went on holiday in Antigua and started an outbreak of measles there. So I think the Antiguan Times basically said, oh, Britain has brought back measles and to Antigua. So it's pretty horrible. So think about it. You know, when you see a rash in someone, whatever age it is, think about it, you know, because it's something we read in medical school textbooks, but we don't expect to see that much of, but it's on the rise. I think there's a final key message, isn't there? Yeah. Effective prevention of infection must be part of everyday practice. That's why we're lucky enough to be here to talk to you guys, because it's really, really important. And you know, it's boring having to teach you guys, but it's important to take these things on board. It affects your everyday practice and affects your colleagues and your patients as well. So sorry we've overrun. If you've got any questions, we're happy to take them. If you don't want to ask us now, email us, contact us. You know, we don't bite, and we're more than happy to answer any complex questions. And we know that when you start, you'll be scared. We don't know what to do. You might be scared to ask silly questions. Don't worry, we've all been there. Okay, so however stupid the question is, just call. All right. Oh yeah, there you go.
Thank you so much for the talk. In my country, I used to take 2 sets of blood cultures.
Oh, good.
But in the UK, it looks like the practice is 1 set.
No, so the latest practice now for sepsis is take 2 sets and make sure you take at least 10 mils in each bottle. The problem we have is, you may know this, but the bottles that you take blood cultures on, they go into a machine, and that machine then incubates and then waits until the change in the colour at the bottom of the sand for it to beep. We don't have that capacity. So in a way, the right thing to do is take 2 sets. And we are actually now recommending in the front line in ED to take 2 sets, because it reduces the number of contaminants that we see. I'm sorry to have to say this, we see a lot of contaminants, especially when new doctors start, and it always correlates. But if we take 2 sets, and we only see it in 1 bottle out of 4, that makes me more assured that it's a contaminant.
Is it, if even if my senior says like take 1 set of blood culture, is it advisable for us to do 2 sets?
I would still send 2 sets.
Okay. Thank you.
Let the storage be my problem, not yours.
Okay.
Thank you. Any other questions? I was going to bring that up actually, so I'm grateful very much. Yeah?
I've got a C. diff question.
Yeah.
So a couple of times in the last week, I've had patients come in or readmit because of C. diff. But because this last stool sample was in middle of September,
4 weeks.
yeah, then we send for a new one, then the result obviously comes back saying we can't validate
What I would
this.
recommend you can do, although Savitha would hate you doing that, what you can do is send for everything else. So do what's called a multiplex stool sample to look for things like Campylobacter, Shigella salmonella, because if they come from the community, despite having diarrhea, they could have been to a barbecue, for example, where they ate some undercooked KFC and got Campylobacter. So if that's the case, we do sometimes see C. diff and Campylobacter, and that kind of somehow helps. But if that patient comes back, it makes me a bit worried that they might need to do some gastro investigations, you know, to look for those.
I think we spoke to you on the phone about it.
There you go.
Sorry, can I just add a couple of things into that C. diff as well? We always recommend if it is in the last 28 days, speak with micros before sending the samples. It's not that we don't want you to send the sample, but there could be an empirical treatment. Is it to reduce the number of hospital-acquired or C. diff cases? Yes and no, but whether what we can do about it. But it's just having that conversations. And one of the recent C. diff PAR, I think we always have to say this, Ward 17. The patient had antibiotics instead of 6 weeks, patient had 8 weeks.
Yeah.
What was the reason? Any guess? Sorry.
I think
No.
when they rewrote the drug chart, they just referred to what was written before as the start date. So really go back and question, like, how long are we supposed to give from which date until which date? Sorry.
I thought that needs to be said because that's sort of a mistake. We haven't seen that before, but it was just, and we thought everybody is busy, but just having a little bit.
Yeah, and it always happens on the weekends, you know, because you guys are stretched, you're covering other people. So it's just be aware, you know, you've got to ask your seniors basically to confirm. I know it's sometimes difficult to do those things.
Thank you very much.
Lunchtime. Oh, yeah.
Do we have an out of hours microbiologist?
Yes, 24/7.
Okay.
You can contact us. But ideally, have a think about what you're going to ask us. We used to say only registrars and above, but nowadays I would say, you know, if you've got a pressing question and you've got no registrar, then plus. But as I said, we recognise, you know, sometimes it's.
But not at 1 o'clock asking this patient has had 6 days of.
Yeah, so think about, you know, what you're going to ask, because I can give you a kind of reason why. I mean, I've had a question about which blood bottle do I take from this, which I got a bit unhappy about, but you know, it's all right. And then questions about, oh, the day team didn't have time to ask, so I'm asking you now at 2 in the morning. And sometimes I just think that could wait till 9 o'clock, perhaps, you know. Just have a think, you know, because we work during the day as well as the night, so you know, it would be good to get a rest sometimes. But we recognise that there are difficult questions. Yeah, call us.
So it's not a confrontation, it's just a question on a lighter note. So I know the policy is bare below elbows.
Yes.
And I do appreciate that, and I always try to follow it. But my question is this watch or any of the smartwatch, if some person is wearing to see the time quickly rather than taking the phone out, because is this one more prone to carry more germs than this huge device that you carry in your pocket all day long, or the lanyards that you're wearing? I mean, I just want to understand the concept of staying bare below elbow. I understand that it's there to stop the spread of the communicable diseases. But sometimes I always try to ask this question to myself, like, how helpful is it to just remove this board and put it back in the bag, and you know?
Thanks again for bringing that up. One thing which I was thinking of, where the elbows is not mentioned here, I should have said that. Just to come to, I mean, before you come to that point, one of the things what we do is like as a trust, we do the bare below elbow, especially in the clinical areas. And then we always say, I mean, previously we said when you enter the clinical area, we have gone a bit more practical now. We say when you are in contact with patients. And the reason why it is when we do the hand hygiene later on, or maybe when we do it, you can see if you have the watch in your hand and you wash your hands, you protect your watch. Washing hands, and then the germs are staying there. Then that doesn't get cleaned very well. I mean, last week I was doing it for some nurses, and then everybody who had the watch and long sleeves on, you can see that it is there. And that is one of the reasons why we say don't have it in your hand. You ask whether the smartphone or this smartphone, you're not having it in the pocket. You don't keep it when you clean your hands. It's nothing stopping you from doing it. So that is one of the main reasons why we say, and then looking at me, I don't have that yet. Yes, doctors do have. We from infection control always says that, yeah, this is here, I always put in the pocket. But again, that's how it is the way, but we have asked the trust to change it into that.
You should all have those yellow badges and not use your landmarks, to be honest.
Yeah. This is where, because that's what we need to know, isn't it? And this is mainly with the, what's that, with the entrance, like that's what that. And this is, I also used to have the fob watch. I know everybody is not a fan of that, having that fob watch. And if you look into something a bit difficult, I totally agree. But this is a reason between phone and a watch having it. And then again, one of the other things, it makes me sorry, we are running on time, but I just wanted to say, because we from nursing staff always ask, you should challenge anybody who is not on bare below elbows. Not that when you're writing the notes, when you're especially going to patients, okay? What happened is one day I challenged one of the, again, this is senior, okay? One of the senior doctor in the trust. And what did she say? I know. Loads of rings, bracelets, and watch, okay? She said, oh, I know. What did she do? Go straight into the isolation room with all these things. Think, how can we ask anybody else to challenge? Infection control says, and then says, I know. And what did we do? We had, at that time, the medical director was the IPSI. So she has given me, if you ever have any problems with the doctors, please come straight to me. I wrote an email to so-and-so. I said, this doctor, it's not that she was not aware about it. She was aware, she was said, but she still went under it. If the senior doctors are doing it, probably when you see this, think it's acceptable, nothing is being done. But then she had long process, okay? Even though she was the senior, it was taken to the STU level, it was put in the appraisal document. So there are actions which we nurses can take. So it's just making sure, that doctors and nurses think, so it's just making sure we are out here for patients.
Absolutely. Thank you.
Lunchtime.
Yeah, so
Thank you very much.
Thank you very much, Dr.
Exactly.
Thank you. Thank you very much. So